healthcare as an industry is notoriously conservative. It is very helpful to come in with the ability to do a pilot or a proof of concept as you're thinking about what would a relationship with this organization look like. But we had people threaten to retire early if they couldn't have the tool anymore. I wonder a lot about the kind of data that we're feeding to our medical AI. I feel like somebody played with ChatGPT over the weekend and all of a sudden the conversation around healthcare and AI changed. I do think we'll start to see less reliance on the general models and an increased reliance on a fine-tune or a setting or industry-specific model. Startups often find themselves culturally at odds with the pace and regulations and internal policies that a large institution brings. Patience is helpful.
Welcome to our new episode of Digital Health Interviews, and we are in Cleveland. Before I introduce our today's guest, I'd like to remind you to subscribe to our channel, like this video, and also please share with anyone who is interested in digital health, but even more interested in AI and healthcare. Also, I'd like to encourage you to support Ukraine as much as you can. I think right now with all the uncertainty that's going on, Ukraine is that even more than ever, so please stand with Ukraine. And now finally, please welcome our today's guest. Her name is Jennifer Owens. Hi, Jennifer.
Hi, thank you so much for having me on the podcast.
Thank you. Let's start traditionally with your background. Please tell us a bit about yourself.
Sure. So we're actually sitting in my alma mater right now. I graduated from Case Western with a degree in physics, which is not a super useful undergraduate degree to have. I went to graduate school for biological sciences. I did some mouse work in mouse models of atherosclerosis. And then I decided that I wanted to work with research participants who could tell me that it was okay to experiment on. So I shifted to clinical research, and that's when I joined Cleveland Clinic. I've been at the clinic for almost 14 years. Yeah, and I have done a lot of things there. I started off as a research coordinator, procuring specimens and entering data manually into a biorepository. And that's kind of where my interest in health data started, seeing all of the ways in which data is generated, in which samples and data kind of flow through the entire system. And then I spent some time in genetics. I spent some time in IT before I took my current role as senior AI program administrator.
Very interesting. I think you also forgot to mention about your podcast.
I did forget to mention my podcast. That's because it's not my job, that's my hobby.
Right, but it's called Health Data Ethics Podcast.
It is, yes.
And I highly recommend you to subscribe to it. I don't know why I didn't find it earlier. I've watched a lot of videos. My favorite one is with your son. It's really nice. I love how he talks about AI and tech in general. Quantum computing is the other one I really enjoyed, but you have a ton of them. So please subscribe. We'll definitely leave a link to the channel. And yeah, check it out for sure. So Cleveland Clinic, I've heard so much about it before. And when you check like different kind of ratings, it's usually like in top 10 or top 5 in the country. And it's huge. I've been walking around like a clinic, and then I went to educational campus, which is amazing. Tell us like what it's like to actually work for such a huge health system.
Oh my goodness. I could talk about this for hours. I really could. There's a reason I've been at the clinic for 14 years. And usually when I do an interview, I start off with a disclaimer that, my opinions are my own and they do not represent my employer. But in this case, I can just say very clearly that my experience at Cleveland Clinic has been, no matter my role, that it was a place that supported sustained learning and a culture of continuous improvement. And I think the best example is when I started at the clinic, like a little baby right out of graduate school, had no idea what I was doing. I was procuring specimens on a biorepository, which means that I was in and out of the ORs. And the ORs are obviously a really highly charged place, not a place where you want extra people standing around. So I went to introduce myself to one of the surgeons just to say, hi, I'm Jenny. I will be in your OR today to grab a sample from this patient they consented to this study. And this surgeon, who was like a leader in the urological center, sat me down in his office, his enormous, beautiful office, and said, okay, well, like, what's your deal? And I said, well, I'm Jenny, and I'm here to tell you that I'll be procuring specimens. He's like, no, 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 you're not going to be a research coordinator forever. Tell me what your deal is. Do you want me to walk you through surgery? Do you want me to tell you, here's what I'm doing, why I'm excising? You want me to talk through my clinical judgment with you? Like the ethos of Cleveland Clinic is such a teaching center. To have that kind of warmth and expertise just extended to me by default was a really fundamental shift in the way I thought about my relationship with the organization. That moment has stayed with me for 14 years.
I love it. But still, I would assume that in such a large organization, the decision-making process is still fairly slow, and there is some sort of bureaucracy there.
There's a lot of organization and a lot of structure at a place like Cleveland Clinic, and it can feel slow. It absolutely can. I think about the bureaucracy as being maybe a necessary process to work through so that our ideas are properly beat up by the time they get to production. I know every idea I have is not necessarily fit for production right away. It really benefits from conversations. It benefits from healthy disagreement. It benefits from having to prove itself through a few different frameworks. And I think the bureaucracy, although it can be incredibly frustrating, and I am often frustrated by it, I think the role that it's playing in the organization is ultimately one that is keeping us safe and responsible.
Well, let's talk for a sec about how Cleveland Clinic works with startups. Is the organization itself open to working with startups, especially early stages, or like as at any large health system, they want some kind of prove that the startup is going to survive?
I think large organizations are often open to working with startups, but it is very helpful to come in with the ability to do a pilot or a proof of concept as you're thinking about what would a relationship with this organization look like. I mean, I've got friends at peer institutions across the country, and this is something that we talk about fairly frequently: is how do you work with a vendor? How do you work with somebody who is bringing you an idea versus an idea that's been developed in house? I will say that the different perspective that you get from a vendor or a startup can be really refreshing and really exciting. I do think, however, that startups often find themselves culturally at odds with the pace and regulations and internal policies that a large institution brings. So I would say patience is helpful, and the ability to really, really test your product, and the thinking about, if you're bringing in, this is what we're talking about tonight, right? If you're bringing in like an artificial intelligence product, how do we demonstrate that this is going to perform effectively in our environment? How do we make sure that this is a partnership that is going to be mutually beneficial?
Does Cleveland Clinic has its own tech team?
We do. We actually have quite a few development pockets sprinkled around the organization. We have a central AI office, which I'm part of, that has data scientists who are doing really fantastic, interesting work. But that's not the only place where we have data scientists and other kinds of people doing development work. There's patches of innovation all over, and there's several other centers that are doing really fascinating work, particularly in imaging and diagnostics and pathology.
When there is like a case on the table when you can work with specific startup or you can build in-house, what do you think management would choose?
Oh, it's so fascinating. I think it depends on a case-by-case basis. Is this expertise that we have in-house? If it is expertise that we have in-house, how does this balance against the other development work that people are doing? Because unfortunately, we do not have data scientists sitting around idle waiting for, like exciting new ideas to come. What is the startup's willingness to work on this? Is it a product that is really ready to go into the environment, or is it going to require some co-development and some customization before we start to think about how this might actually be put into production? It's truly a case-by-case basis, and it's something that we think about a lot. How do we decide whether we're going to buy or build this thing?
AI.
Yeah.
Obviously, everybody's talking about it for the past few years when ChatGPT appeared and Gen AI in general. Well, first question, actually, AI is obviously used in healthcare for many years, even before Gen AI appeared. Is that something that people were talking about for many, many years, or is actually this hype that appeared with ChatGPT, it came to Cleveland Clinic as well?
So I think both. You're correct to say that AI has been in the healthcare system for many years, even if we wouldn't necessarily have called it artificial intelligence. And then I feel like you could see the change in the discussion when a bunch of leaders kind of got together, and I feel like somebody played with ChatGPT over the weekend, and all of a sudden the conversation around healthcare and AI changed. It turned into, this is hype and this is not safe and we will not be using this, all of a sudden to, ooh, what could we do? What could this do in our ecosystem? What could we think about using this for? And that was a really fascinating turn to kind of navigate, because that was when I was learning and sort of growing my knowledge base about artificial intelligence as well.
So when some of the decision makers on the top level found out about Gen AI, are they like, oh yeah, let's explore how to use it, or let's wait, let's be more cautious about it?
So again, this is not a perspective that's limited to Cleveland Clinic, but I will say that healthcare as an industry is notoriously conservative. And so when Gen AI first came on the scene, the discussion was not, ooh, let's do this. The discussion was, we need to govern this very closely, very carefully. And that thought, that thread, that desire to make sure that we're using artificial intelligence responsibly and ethically is not gone. It's still there, but it is now married with a desire to say, okay, well, what can this do responsibly, safely, and ethically? If we take these ground rules into effect, how can we use this?
Tell us, we're now in 2025.
Yeah.
Tell us some of the use cases of how AI is being used, or Gen AI specifically, in Cleveland Clinic right now. So
we can talk about Gen AI specifically. We have some development work that our teams are doing with large language models, which is fascinating. We have, in the field in general, there's a ton of artificial intelligence scribes that will listen to an ambulatory encounter. So you sit down with your primary care doctor, you say, hey, I'm in today for a sore throat, and your doctor says, fantastic. Can I stop you there? I'm using a tool that will help me, document this encounter. Pull out your phone, it listens to the entire encounter, drafts a note for your doctor then to go back, review, edit, and approve. So it's not completely autonomous, right? This is assistive AI technology. And it really can cut down on the documentation time. It cuts down on the time that ambulatory providers are spending doing documentation after clinic hours. It's an amazing use case for a large language model in any healthcare ecosystem, but in Cleveland Clinic's ecosystem as well. I know our AI partnership, our AI-scribe partnership, has made the news. We're working with Ambience. That way, rollout is actually happening right now as of this recording. I'm really excited about it.
Did you go talk to doctors before starting implementing that and getting their feedback first?
So we did a lengthy pilot. So when you were talking about startups and working with large healthcare systems, we did a really intense pilot series. We worked with 5 different vendors to really test their product in a setting like Cleveland Clinic, right, where we don't just have primary care providers. We have surgeons who are seeing patients in the outpatient clinic. We have cancer doctors. We have a whole children's hospital, which is like 10 or 11 subspecialties all bundled into one place. It's really complex, and we really wanted to test and make sure that the technology was ready to take on that complexity. We talked with doctors before the pilots. We talked with doctors after the pilots. We talked with doctors through the pilots to say, is this actually helping? Is it saving you time? Do you feel less burnt out? Would you grab your friend in the hallway and say, you absolutely must try this tool? And now that we're rolling out our full implementation, we're making plans for how we're going to continue to probe those points with our clinicians who are using the tool. That's really important that we make sure that it is still having the impact not only on the metrics that we're tracking, but also on the emotions of our participants. We put this into place with the intention of lowering feelings of burnout and making people's lives better. If it's not making your life better, then we need to reevaluate the technology.
So I assume most of the doctors said that it's making their lives better.
We had some amazing verbatims, and these weren't all from Cleveland Clinic, because we talked with other groups that were using some of these vendors as well. But we had people threaten to retire early if they couldn't have the tool anymore, if it went away at the end of the pilot and they couldn't have it. We had people email, actually we had a patient email our ombudsman's office to say, my doctor used this and I have not had so much face-to-face contact with my doctor in the entire time we've been, we've had a therapeutic relationship. They said it was amazing. We've had doctors rave about the amount of time that they're saving in the evenings, that they're able to go home and spend time with their families instead of sitting on the laptop finishing up their documentations. We had doctors say that it actually saved them mental effort trying to recall, okay, which patient was it that came in for something and then also had foot pain. Just the overall cognitive load of documentation is also reduced. So we want to make sure that that holds as we continue our full enterprise implementation.
I've talked to a few doctors, and there's one concern that just wanted to hear your opinion about the the approach of saying verbally everything doctor thinks has to change, because in many cases doctor is listening to your lungs and might hear something that disturbing, and usually doctor would not say that out loud, because none of the tools, the AI-scribe tools, are recording that, and he doesn't or she doesn't want to scare a patient. How would that be incorporated in all this AI-scribe process?
Sure. So you have a couple of choices. I actually was shadowing with a pediatric doctor I think it was last week, just to kind of see how this tool is working in their clinic. And you have a couple of options. So you can absolutely retain that information and then do some post dictation after you leave the clinic. After you leave the exam room, you can say the lung exam indicated some crackliness in the upper quadrants. Or you can wait, hold your thoughts inside your head, and then when you go in to edit the note afterwards, you can add that back in. There's a few options. If it's something that you want to capture in the note and you know it in advance, you can also do pre-charting on the patient. So you can go ahead and start your dictation before you enter the exam room.
Besides scribe tools, what other use cases you are mostly excited about?
Oh boy, one that I'm really excited about, and there are a couple of companies that are doing this, and I feel like the technology is really interesting. I'm really interested in the ways that we interact with the medical record. Medical record is a huge, deep well of information about the patient, and not all of that is relevant in every clinical setting. So I'm interested in the companies that are working really hard to figure out how do we surface the information that is most relevant to every person caring for that patient. And that's going to vary based on the role. It's going to vary based on the setting. That is a complex, like a really, really complex and changing challenge. And I'm really interested to see where innovation goes in this space.
Watching your videos and even now hearing, you sound very optimistic about AI, but we all know that there are some limitations, some barriers of adoption. What do you think about hallucinations or potential exposure of medical data to general models and other issues?
These are huge concerns, and I don't mean to seem like I'm being flippant about them. So yes, I do have concerns about hallucinations, and I particularly have concerns about hallucinations not giving rise to, but hallucinations and algorithmic bias, right? So an experienced clinician of many years may look at an AI output, like say a suggested diagnosis. They may look at that and say, no, this is nonsense, we're going to wipe that out. Somebody who is less trained or has less of a body of knowledge that is AI independent may look at that and think, well, the AI has been reliable 80% of the rest of the time, I guess this is okay. I worry a lot about that kind of bias dragging us further down, like a model that is 95% reliable. Not that humans are 100% reliable either, but it changes how you feel about it when you realize that you have essentially given up some of your agency to the algorithm. I do also worry about breach of medical information as we're working with third-party vendors. That's another concern, right? We protect our own data inside our own walls, but with a vendor, you want to make sure that your contractual relationship is really well defined, so that we understand that you're going to treat my data with the same care and security that I would. I wonder a lot about the kind of data that we're feeding to our medical AI. So, that healthcare is biased. Healthcare data is biased. Not everybody has equal access to healthcare. Not everyone is treated the same by the healthcare system. And so the healthcare data that we have that we're training models on reflects the bias inherent in the system. And when you train a model on that, you have to do so very carefully so that you're not crystallizing and baking in that bias into your algorithm, so that you're continuing to perpetuate inequities. And instead that you're using AI to provide better access to healthcare, equitable care to all populations, making sure that every patient who comes in receives the same quality of care.
So we recently had this episode on Digital Health Inside Out channel, and we talked a lot about medical AI. Still, most of even scribe tools, they're using general models. They're probably top 5 or 6 right now available. Do you think at some point, maybe Cleveland Clinic or someone else will actually come up with a specialized medical model, so we don't need to use the model that was trained on all the open source data in the world?
I think a specialized medical model would be of immense use in healthcare. And I think it will be interesting to see, just like we've had consortiums rise out to deal with clinical research, we had consortiums rise up to deal with genetic data. I think we'll start to see some collaborations emerge. I think we'll start to see some groups kind of coalesce around centers of excellence for this kind of thing. And I do think we'll start to see less reliance on the general models and an increased reliance on a fine-tune or a setting or industry-specific model.
Wanted to step back for a second from AI and talk about interoperability. We all know that this is a big problem in the US. Do you see any shift in the positive direction in solving this problem?
Hard to say. I see lots of opportunity if we can change the way that we think about interoperability. So one of the things that I'm thinking about a lot is if I'm a patient who has been referred to Cleveland Clinic, if I'm bringing my medical records from another location, what is that experience like for that patient? Because often you get told, I don't know if you've tried to seek care, but you get told to fax your medical records over. Do you carry paper medical records?
No.
I don't carry paper medical records. And a fax machine. Like if I had to find a fax machine, I would have a problem with that. The interesting thing is that under our current interoperability protocol, we can't, either the patient has to initiate sending those records, but we cannot issue a request for those until we have established a therapeutic relationship with the patient. If we were to push that window out a little bit, if we were to say, you know what, the patient is seeking care here, can we go ahead and get that data in? I think that will make an enormous amount of difference. Because going back to your question about bias, I start to think about data privilege, about having all of your data accessible, about making sure that all of that data is reliable. So like, for example, my children have been Cleveland Clinic patients since they were born. All of their data is in one place. I am slightly older than my children. I have amassed, medical records that span several areas. And so there are parts of my medical record that Cleveland Clinic does not have access to. If that information would be important in an algorithm to predict like a fall risk or a risk of developing a chronic disease, that information isn't there. So I have a bit of data lack of privilege, I guess, and my children have data privilege because all their information is there. I think about this a lot, and interoperability really plays into this because if you have a condition that's led you to seek care at multiple organizations, collecting that data and getting it all in one place where you can actually operate on it is an enormous task.
Where do you see healthcare in this country in 10 years? Like what kind of changes you expect and you think that are realistic to happen in like next 10 years?
Oh my goodness. This answer varies a lot on whether I'm feeling optimistic or pessimistic.
How are you feeling today? More optimistic?
So we'll go for an optimistic answer.
Right.
Okay. I feel like supportive artificial intelligence, the kind of artificial intelligence that will ride along with a provider and suggest diagnoses that they may have missed or that will mine the medical record and bring up conditions that the doctor may not be thinking of. I think this will be a great extender for care in rural areas and places where access to care is geographically limited. This is, I grew up in a small town, right? I had the privilege of being treated by an amazing doctor, but not every small town has an amazing doctor. So for those places that where maybe getting to the hospital is a 30 or a 45 minute, gap, can we do some telehealth for them? Is it possible to combine telehealth with, some sort of AI mechanism that would say, we need to get this patient to a surgery center, we need to get this patient elsewhere? I think that will be an immense increase in the access that rural Americans have to care. I think that the way we think about reimbursement is going to shift slightly because I hope we will see a slight shift towards thinking about the output of artificial intelligence as true medical information that can be considered for reimbursement. So, excuse me, like if I have an algorithm suggest that perhaps I have diabetes, will my glucose and my A1C testing be covered by my insurance if I didn't have a human being suggest that I have diabetes? That kind of thing. I think that will be interesting, and that will also drive the directions that innovation tends to go in the United States.
Very interesting. So I started our conversation with asking about startups and how they work with Cleveland Clinic potentially. So at the very end, can you give some kind of recommendations? And I'm sure lots of startup founders are watching this episode. Someone there has a really great solution potentially for Cleveland Clinic. what's the best way to approach Cleveland Clinic? Should they potentially reach out to you personally, or there's like, I don't know, a hotline where you can call, hey, I have AI solution. Can I do a
Save
pilot?
my inbox. Please don't reach out to me directly. Not that I don't want to hear from you. But there are definitely mechanisms to get your product in the hands of the correct people at Cleveland Clinic. What I will say is that, and I don't think this is unique to the clinic, I think that many other healthcare organizations have this. We're a physician-led organization. If your product has a clinician champion, it will go much farther because that clinician champion can help shape a specific use case for the health system that you're trying to work with. So I would actually start by going on the website of the healthcare organization that you're trying to target. Look for folks in your specialty area and reach out to them and say, hey, are you open to hearing, 10 or 15 minutes of a pitch? I think so clinician support is the first place I would go. Second place I would go would be IT support, because in a world where healthcare budgets are shrinking, IT shops demand far outstrips their capacity, and having a really clear understanding of what your ask is of them will really help you. That's where I start.
Do you need to come to that call with some actual ROIs?
It always helps. Everybody loves a good call where you get all starry-eyed and you think about all the things that you could do. That's very energizing. But for concrete next steps, having some ROIs and some thinking about where is this project really going to go and what is the impact going to be in this specific case. So for this health system, for this patient population, it's tremendously helpful.
I love that. Well, let's meet a few years and see how your predictions is going to happen or not. And yeah, very excited to learn more about AI in Cleveland Clinic.
Thank you so much for having me. This was so much fun.
Thank you.